Hello, and welcome to Healthy Longevity. I'm Florence Comite, founder of the Comite Center for Precision Medicine and Healthy Longevity. I'm really super excited about today's podcast because my guest is a woman that I have much respect and admiration for, a woman who has played all 9 innings of a contest against breast cancer and then some. Joelle Kaufman's mom had breast cancer. Her sister had breast cancer, so Joelle was a cancer caregiver, before she actually became a breast cancer patient herself. She endured the fear, the uncertainty, the decisions, the procedures, the setbacks and disappointments that most cancer patients face and experience. So who better to write a book that not only chronicles her journey as a cancer patient, but as an incredibly useful guide to navigating the challenges of a cancer diagnosis. The book is really filled with tools, advice, and compassion that can really help both patients and their loved ones. It's called Crushing the Cancer Curveball, a playbook for the newly diagnosed and their family and friends. Welcome, Joelle.
Thank you. It's great to be here.
And I'm also delighted that we have a special guest that's joining us, Dr. Lauren Esserman, a nationally renowned breast surgeon and director of the University of California, San Francisco Breast Care Center, who actually performed Joelle's surgery. Welcome, Dr. Esserman. Glad to have you.
Thank you so much. Thank you so much.
Should we drop the formal names and just go by Florence, Laura, and Joelle?
Absolutely. That's fine, yeah.
Okay. Great. Anything you want to add, Laura?
No, I think the only thing that I would say that's like I've devoted my life to trying to figure out how to improve the way we treat and reduce the risk of occurrence of cancer, progression of cancer. And, I think I'm working on advancing that knowledge through large national trials where people can get better care and where we can also be learning so that we're helping the next person who comes along.
That's a fantastic goal. I admire it deeply. It's hard to accomplish, but you're part of the way there just in the work that you're doing, which is fantastic. I'll go back to Joelle for a minute here too, because besides being an author, she's CEO and founder of GTM Flow, which coaches and consults CEOs and other leaders of companies, mostly in the high-tech world. Did I get that right, Joelle?
You did great.
Excellent.
You did.
So what I said at the start, your book is not only incredibly informative for people facing cancer and their loved ones, but I found it both comforting and compassionate. And I can only imagine that you could have benefited from such a book during your journey.
Well, that's exactly right. Like the first time, and hopefully for most people, the only time you face cancer, it's disorienting. There's a bunch of doctors and language and terms that as a layperson, you're not familiar with. And even though it's not an urgent crisis most of the time, it feels very urgent. It feels like now that I know, I have to do something right now. And while I don't think any of you would say we should delay for a long period of time, one of the things that I realized was the second time we saw cancer, and to be clear, Florence, I think I was number 12. So I've really seen this disease. I don't know anything about any other disease, but I know something about what it's like to be a caregiver or a patient of this one. And it is so much easier the second time because all of those things that were unfamiliar have become predictable. You know you're going to need more tests. You know you're going to need more scans. You know you're going to see multiple doctors, and that those doctors are not going to give you a definitive plan until they have gotten a bunch of data and probably conferred with each other. And so you don't feel anxious that they're not giving you a precise plan because you know you're not getting one until there's good data. And one of the things I wanted to do with the book is give people, if you will, a life ring, or I called it a playbook, for those moments when you've just heard news you never want to hear. It's the hardest news. I actually called the surgeon who told me and thanked her for the kindness with which she told me, because it's got to be awful to have to tell somebody, I'm sorry, it's malignant. You know you're rocking their world. And you don't have answers about everything that's going to happen, or the really pressing question, am I going to be okay? Right? So without being able to answer that question, because I can't, I wanted to give people a playbook so that they could unpack, this is a set of things that will likely happen. And then it really became a mission. Because the narrative, when you hear it's cancer, the first thought is, for most people, I'm going to die. It wasn't my first thought. That doesn't make me special. It makes me the daughter of a 43-year survivor. The sister of a 20-plus year survivor. And that's a perspective shift most people don't have the blessing of having. So my first reaction was actually, you have to be effing kidding me. Because it was the day before I was supposed to have a prophylactic mastectomy and deep flap. And then I said, okay, so we'll do the surgery tomorrow and then we'll deal with it. And the surgeon said, that's not how we deal with your type of cancer. And so another thing I wanted to do in the book was change the narrative so that people knew this is something you can get through. And I can't promise outcomes, but you can get through it in ways that are more or less bad. And I was able to transform it into one of the happiest years of my life. And I mean, I remember a lot of times laughing with Dr. Esserman, or I'll tell the story and she'll add to it. But Dr. Esserman, when she takes her patients into surgery, she offers to sing for them. And it's a wonderful thing, and it's very calming, and it humanizes the whole thing. Turns out I'm a singer too. And so when she told me that, I said, what do you think about a duet? And so we duetted me into surgery and into anesthesia, and it just put a smile on my face. And I hope it put a smile on your face.
Wow. Yeah.
And I think that's a good way to go into a big surgery.
Absolutely. I think you were in a unique position, though, and we can start back when your mother was diagnosed. But the fact that you can say it was the happiest year of your life when you got a diagnosis that you know could be devastating, even though you lived through other people's experiences, your closest family, is almost an oxymoron that you can feel that way. It's not common. So the fact that you can give people some both perspective and insight is great, and that you yourself can say, by becoming familiar with what this could mean, my world was rocked, but I managed to own it. I owned the process, even though it sounds like you also, it was changed for you the night before you were expected to get the care you were going to get. You had to completely revise everything in your life to be able to cope with it. So that's pretty admirable.
Yeah. Well, whether or not it was admirable, I mean, my memories of chemotherapy from my sister and my mother were awful. And thanks to work like what Dr. Esserman does and the teams at Yale, at UCSF, and here, there's so many more options. And there's palliative care to deal with some of the options. And a lot of people are so paralyzed by the diagnosis that they don't know that there are a bunch of questions they can ask. And, you know, at no time, I had a great team. Dr. Esserman and her team are extraordinary doctors, and I feel very lucky. And I wanted to be their partner. But that didn't mean I came in bringing Google readouts. I never did that. Frankly, I'm confident. I felt very confident that Dr. Esserman, Dr. Chen had the state of the art and that they were offering me the best possible for the longest, best impact. And that confidence was really reassuring. And it allowed me to ask questions like, can I take this supplement? Yes, no. What does this mean when you said I shouldn't have sex? Like, let's talk about that. That was Dr. Chen. That wasn't you.
I was going to say. And so
we fixed that. We fixed that problem. It wasn't that. I had misheard. And you mishear all the time in this conversation as the patient. Even when you record it, because you're adding a narrative in your head. Well, what did that mean? Or did I hear that right? Or am I going to be able to work? What's it going to do to my kids? What's it going to, if you don't have kids, what's it going to do to, if I want to have kids? My sister was diagnosed at 29, 3 months before she got married.
Diagnosis of your mother and your sister. You were 13 when your mother was diagnosed, and then your sister later. How did it impact your family? You're talking about your impact, and actually a lot of what you just said should help the listeners, because if this is something they're facing, or they faced it through best friends, close friends, or family, it sounds like it might be helpful to have somebody with you to translate, to be there and support, or even look for support from people who've survived it, who may not have your family history and are alone with the diagnosis for the very first time.
Yeah, one of the things I suggest, and it's probably different for everybody, but because of the timing, and I'll answer your question about my mother and sister, but because of the timing when I found out I had cancer and I wasn't having surgery, I had a unusually large group of people that thought I was having surgery the next day because I knew I was going to be not working and I might need help and my family might need help. And so there were a bunch of people who knew I was having this big surgery that I wasn't having. And so I tend to encourage people to tell people, probably not the day you were diagnosed. That's probably not the best day that you're telling people. I ended up telling a couple hundred people the night I was diagnosed. And so what I did, though, and this is important for your listeners, when I told people, I said, it's a curveball. I actually said, the universe flipped me the bird. I was diagnosed. It is this. It is triple negative. I know what that means. Please don't send me links or stories. Here's what I do need, though. I need an oncologist. I don't have an oncologist like most people who don't have cancer. Why would I have an oncologist? I really want to work with people at a national comprehensive cancer center. Did I use the right word?
Mm-hmm.
Right? And I live between two of them. So, I need an oncologist. I'd prefer they be at one of those two places. And I do not know the plan. So please don't ask me or my husband or anyone else. We don't know the plan. I'm starting a Caring Bridge, which is a website that you can privately blog and share information. I will update there, and we will let you know if you want to help, what help we need. Because what I remembered when my mother went through it, the day I was told my mother had cancer, I was 13. I was like, this isn't possible. This is a 36-year-old, athletic, fit, strong, incredible woman. What are you talking about? Cancer happens to old people or sick people. No, it didn't. Cancer happened to a healthy, vibrant person who is now a 77-year-old healthy, vibrant person. I think that's also great. But I went to the library and I researched and decided she's going to live. And being 13, it was very black and white. It was fine. Little stupid, but it worked for me at 13. But when she got what's a local recurrence, and Dr. Esserman, I don't know if I'm using the word right, it was in the same location, like on the scar line of where her mastectomy had been. So they didn't believe it was a new primary or a recurrence. They believe it was kind of left over. Does that make any sense?
So it was we call it a local recurrence.
Okay. So a local recurrence. That rocked our world. That wasn't supposed to happen. And when she went through chemo and radiation, it was very isolating in the 80s. People referred to cancer by going, cancer.
When they did
right?
refer
they wouldn't
to
talk
it.
About it.
Yeah, you kept it a
at
secret.
All. But, right, some contagious disease, which it's not. And so my parents were very lonely and very scared and very isolated. And my sister and I were very lonely, scared, and isolated. But she got through it. We got through it. Our family's tight. They supported each other. 20 years later, when my sister was diagnosed, also 2 months post doing an Ironman. So again, at the height of fitness, we knew this isn't happening again. We didn't know about the gene yet. And she chose to allow people to help, and people wanted to. And so there were people bringing meals or people driving or visiting. And I wouldn't say it was a happy experience because she had a very aggressive, toxic chemo that I am glad I was able to avoid. But I saw the power of having a community supporting you. And so when cancer came for me and I told people, I did know some of the things that would help. And I joke, there's a chapter in the book, it's either chapter 15 or 16. It's all the things that someone who doesn't have cancer can do to help someone who has cancer without having to ask the person who has cancer, because that's just more work, right? So I was really lucky. My best friend is a phenomenal organizer. So Jessica took on, I'll do the meal plan, I'll do the driving to and from UCSF, and just took that off my shoulders. She also handled telling people, no, we're not having a party because she's not having surgery. I was going to do a whole bye-bye boobies party, which I did May 3rd, but I could not do in January. So anyhow, I welcomed people. And the reason it became one of the happiest years of my life is because I never felt so loved and supported and cared for in such a meaningful way with very small steps by lots and lots of people. But your point, if you are diagnosed and you feel alone, ask your team, ask your surgeon, your oncologist, whoever's telling you, is there a social worker? Is there a support group? What is in the community? This is unfortunately, and may it not be in the future, a relatively common occurrence. And there are probably people who can tell you, I've walked this path, and I don't know that it'll be the same for you, but I'm here.
Right. And I think it's important to know, though, that everybody's experience is not the same. Everybody's path isn't the same because, as you yourself say, all these cancers can be really quite different and the kinds of treatments are different. And you want to be careful. You want the support, but you want to be careful about having lots of advice from people who really don't know the nuances or the differences and the types of cancer. Oh, well, my Aunt Sally had this, so why? That's not necessarily helpful. And a lot of people do go to the internet and look at things, and some of the things they look at are good and some of the things are not. But I think key messages are cancer is not an emergency. It's an emergency because you know about it. You have the time, and it takes time to get to understand what the biology is so that you can really have a program of care that's tailored to the type of tumor that you have. The old standby is you do surgery first, then you figure it out, and then you give things and hope for the best. But we are trying to do things differently now so that we can figure out what kind of cancer it is. And if it's a small kind of indolent or what I call a shoplifter cancer, then maybe all you need is surgery and maybe you don't need radiation. It really depends on the type of tumor, what it is. Or maybe you can have, if it's precancerous, there are options for active surveillance and there are trials for that. We have a trial called Recast DCIS. So there isn't one size fits all. So no one size fits all. Wait and get the data. Make sure you ask questions. Make sure you say, wow, is there a clinical trial that could be right for me? Because that could be part of care. If you have a larger tumor or a tumor that's growing faster, in particular, those are the cancers where you want to do the systemic therapy, the whole body therapy first, because in the course of care, you learn whether or not that therapy is working. And if it's not, you can change courses. We have a big trial called the I-SPY trial, which allows us to start with novel therapies. And if that doesn't work, we go on to the standard of care that's best for your particular subtype. And if that doesn't work, then we have something else. But it gives us an option to start to drive some of these new therapies into the treatment earlier. And if you get to a complete response, we know you're going to be okay. And then you don't have to worry about it. Or if you do have a lot of disease left, then we can change course and do something else. So knowledge is power. And I was just going to say, and when you go to an appointment, it's good to record that appointment. At UCSF, we have a program where we provide decision support, and our patient support core will come organize your questions, come in and take notes for you and record the conversation. So sometimes when you get nervous, you forget what questions you were going to ask. So if you've prepared those questions ahead of time, and you can do this yourself too, if the service like that isn't available, but to have someone help you ask questions and have someone take notes for you and always say, can I record this? And everybody should say yes, right? It's because then you could go back and listen to it.
That sometimes doctors are not that comfortable having their words recorded, but most of the time nowadays, and in fact, there are services in New York where they actually buddy you up with somebody who's been a survivor or lived through the cancer. So you have an experience, not unlike you, Joelle,
right,
who lived it because of your mother, then your sister, but where you can get some insider information. And to me, it goes beyond knowledge. It's wisdom. So a lot of times when I diagnose cancers in my patient, including breast cancer, I will find somebody. If they don't have anyone, I will find someone that I know, either through my personal relationships or professional, to say, would you mind talking to this particular person because I think she's similar to where you are and has a diagnosis that's similar. Even clinical trials are not necessarily understood in less sophisticated areas. New York and California are exceptions, but there are plenty of folks in between New York and California who have trouble sometimes finding sources of information that both comfort them, but also give them a helping hand. And I think that's what I hear you saying that you try to do, set up.
That's right.
Yeah,
that's right.
That's great.
And, and really to make sure if someone is young, were you thinking of having children? Is this something that you want, that you can freeze your eggs and prepare for that if you need chemotherapy, that you can preserve that option if you want, even if you're having just hormone therapy, you may need to do that for 2 or 3 years. And if you're 35, that may not be, you may not still be fertile at 38. So these are questions that you have to ask. There's certain things you want to ask if you're young. There's certain other things you want to ask when you're older. Who's your support? Who can help you? These are the kinds of things that Joelle is trying to make clear. And not everybody has that experience of knowing it so well. The other thing is that, everyone wants to know what caused the cancer and what did they do wrong and are they being punished? That's not how cancer works, right? And it's, we like to say that, I forget who Arthur Anderson turned into, but, there's a Accenture. That's right. So like the thing is, if you, what do they say? You can have a 2% accounting error. If your body had a 2% accounting error, no one would live past a year of age. So, if you've got billions of cells dividing all the time in those particular types of tissues where there's cell division all the time, which happens, every menstrual cycle, things grow in various things like the breast, prostate, all these things go on. That's why cancers are more common and these kinds of organs. And it's not because of X, Y, and Z. There are things that people can do to reduce their risk. But sometimes if you have an underlying risk or something goes wrong, you can't always avoid it. So there's nobody to blame. There's, okay, what can I do about it? How do I protect myself best about it not progressing? And how can I also make sure that I don't let the fear of this crush me?
That's right. I think that's right. I remember asking you in my first appointment with you, we had a moment. There were 2 moments I remember besides when Dr. Esserman walked in. One was she was looking at my MRI from 6 months earlier and my MRI from when I was diagnosed. And she looked at it and she turned to my oncologist, Dr. Chen, and said, "This is so cool." And I said, "Cool? What's cool?" What was cool is it totally wasn't there in June. There wasn't a glimmer. And it was there in January. And I actually do think that's cool because it was found. Right? So I always said, I'm in the 10% that our cancers are known genetic. Okay. And that meant, and I had a very, very high lifetime probability. So none of this was shocking. But it was great that because of my risk, and
nobody looked. It would not, right. So that's what I'm saying. You got to know, what's the underlying risk. So what you don't want to do is find a surprise. It would have been very different if on the pathology I said, "Oh my gosh, you have a cancer," and I wouldn't have been able to have given you a treatment ahead of time that made it go away so I could tell you, "Okay, don't worry about it. We've cured that cancer and now we've taken away your risk of getting a second cancer." Those are things that bring people comfort. That's why we've changed the way we do therapy. We don't, I've been working for decades to try and change the frame of people so that we can have maximum information to help people get the best outcome. And also, because that first 4 cycles of therapy worked, you didn't have to have anything more. You didn't have to have anything more toxic. So that's what individualization of care is. And the kinds of trials that I try and develop are ones that allow us to individualize care at the same time that we are testing new things. And also, I think it's illustrative. Joelle knew that she carried a mutation that brought her risk. Most people don't have any idea what their genetics are. And what we usually do is say, "Oh, if you have a family history, then let's test you." But in fact, that's not a great test. We run a study called the Wisdom Study, where we are trying to start the whole process of screening by understanding what the individual's risk is. If we don't treat all cancers the same, and people don't and have different risk factors, why in the world would we screen everyone the same. So what you want to do is start with risk, and then based on that risk, you figure out when to start, how often to screen, and with what modality, and then figure out if you're at high risk, what can you do to lower that risk. That's called the Wisdom Study, but everybody gets genetic testing. And what we found in Wisdom 1.0, we're now on 2.0, what we found in 1.0 was that 60% of the people with mutations did not have a family history.
Wow.
And there's lots of reasons for that. You know, people don't always know their family history. People can come from small families. Some people are adopted. Maybe people don't talk about things. But even for someone with a BRCA1 tumor, 40% didn't have a family history. Now, part of it was that we were starting to screen at 40. And that's one of the reasons why we started at 30. So in the I-SPY trial, which is, for people who have stage 2 and 3 aggressive breast cancers, 85% of the people in that who show up in that type of tumor were not screen detected. Their cancers weren't discovered on screening. So what that tells you is that's a different kind of cancer, and we're probably not doing a particularly good job of finding those cancers.
How were those cancers uncovered, Laura? Because I know that
someone finding their own cancer
with their hands.
So like I put my hand on my breast, or I fell and all of a sudden I fell at this, or you have a symptom, my breast looked funny, all of a sudden.
And these are in women who had prior mammograms within the year?
Right. Often, or the average age is 46. So that means a lot of people are young. For the people who get cancers in their 30s, it's not as common, but it happens. Right. And there's more of it. And in fact, it is. And when you are young, you tend to get more of the aggressive, the more aggressive cancers are more frequent. They're more like, 70%
I know I just
of
had
them.
a recent case of a 32-year-old with a young child with a similar presentation, completely shocked by the finding.
So now the Wisdom Study, which is open to anyone in the country, regardless of insurance, regardless of where they get their care, it's all an online study, starting at 30. Because what we want to do is find the people with the highest risk, find the people who either have an inherited change in one of these mutations or genes, or they have something called high polygenic, poly meaning many, genic genes risk. Turns out you inherit lots of other genes. That's what makes your hair blonde or dark, your eyes blue, green, or brown. Your genes direct everything. So there are, thousands of genes with slight variation, this, that, or the other, but they're combinations, and we're increasingly learning more that can predispose you.
Yes, I can actually talk about myself and my family in that way. But before we leave this topic of the genetic variants, one of the comments that Joelle wrote in the book was the BRCA1 gene was woven into our DNA fabric like an unwanted heirloom. But then you go on to admit that you did next to nothing about it. Was there a reason that you did next to nothing about it?
Well, okay, let's talk about the continuum of next to nothing.
You were about to do something big.
And so first off,
until you had the surgery set up, yeah.
No, there's more.
Okay, great.
Down the path. So when my sister was diagnosed, I was 40 weeks pregnant. And I did what every daughter of a cancer patient or sister does. I called my doctor and said, this just happened. And my doctor said, go to the breast center and get a mammogram right now. I was like, I'm 40 weeks pregnant. She's like, go. So off I meet another doctor that's in the book, Dr. Harriet Borofsky. And by the way, I'm a really small person, Florence. Like I'm 5'2". So when I was 40 weeks pregnant, I was massive, like very odd looking. And so I show up, Harriet greets me, brings me back. I said, how are you going to see anything? And she's like, well, I'm going to see a lot more than I'll see in 2 weeks when you deliver that baby. So let's go. And Harriet became, for 20 years, my breast imaging doctor. So I was doing, and she set me up, at this point, we're talking about 2003. So she started me with mammogram, ultrasound, and MRIs. And then later she said, I want the MRI to move 6 months out so that we're looking at you every 6 months. So that was her strategy for someone with my profile. And I decided after a biopsy to get the blood test. Turned out I did have the gene. And I said, okay, after I had my third child, I said, they recommended a salpingo-oophorectomy, which for people who aren't medical who might be listening is the removal of your ovaries and fallopian tubes. And they said not only will that reduce the risk of ovarian cancer, which comes with BRCA1, but it should half your risk of breast cancer. And my sister-in-law, Dr. Heather Stein, also in the book, she basically got on the phone with me and said, Joelle, from
epidemiology.
Yes,
right?
that is a huge improvement, and you should do that. You just should do that. So yes, it means you're going to be in menopause, and there are hormones, and there are doctors who can help you through that. And interestingly, I had read the study that you talked about in last week's episode, and that said, oh, but hormone replacement therapy is dangerous. And the surgeon who did the salpingo-oophorectomy, he said to me, yeah, but that doesn't apply to 38-year-old women. That's not you. You would have these hormones, so let's keep you on hormones, at least for a while, and see how you do. Because of bone density and cardiac, and I don't need to tell you, you're the expert. So I did that. I did the salpingo-oophorectomy, and I did aggressive screening with the theory, up until I was about 52, that if we found it, it was going to be early because we were watching. I mean, I couldn't see a physician on my team for anything without getting a breast exam. And I was doing breast exams. And, one of the things I want to say about your what you talked about with I-Spy and with younger women is too many of the women I talk to were told it's nothing. When they said, I feel something, and a doctor says it's nothing. My sister was like, I feel something. The doctor said it's nothing. It'll go away. A month later, it was still there. She's like, you know what? I want nothing out. And I don't know, maybe you two can explain why. I was like a pincushion with biopsies. People thought they saw anything, they were going to biopsy it.
Because they knew you were a BRCA carrier.
So you came later into the diagnosis. And did your family know at some point? Your sister was early, your mother was even earlier. And doctors tend to want to make light of things unless it grows into something serious. Most of conventional medicine, which is not the medicine standard of care I practice, I actually practice a form of precision medicine, and of one, because just like your belief, Laura and Joelle now, each one of us is unique. Even my twin sister and I'm an identical twin. We have a different history, we have different conditions, and we live a different life. My whole family gets breast cancer. All my female cousins, and I have 27 of them, and my mother was one of 8. And it turns out that genetic variants go beyond BRCA, and there's a lot we don't know. For example, I don't detoxify well. And so that is probably one of the reasons it's an interaction that I have been made aware of by genetic experts, Dr. Laura Hausman-Cohn out of Austin, who does work in genetics. And we screen all our patients with 1,700 gene variants, and we can help them sidestep certain choices and ways of living to minimize the risk, to help them detoxify if that is the issue. Because BRCA, Laura, correct me if I'm wrong, is less than 1% of breast cancer.
Actually, of the people who get breast cancer, it's about 10%. Of the people who have locally aggressive or stage 2, 3 breast cancer, it's about 20%.
Wow, okay.
Probably.
I was always under the impression it's a small diagnosis.
And in the population, if you take the population, it's 1 to 2% of the population has it. But it's important to know who that 1 to 2% of the population is, because there's lots of things you should know, lots of choices you can make. It changes the way you screen. You might want to think about prophylaxis. Maybe you don't want to think about, you can remove your breasts if you want. You don't have to, but at least then you should be screening very carefully. And now we have better tools, right? You can alternate, contrast screening exam is probably.
You're talking about MRI or magnetic resonance imaging?
MRI, magnetic resonance imaging, alternating actually with contrast enhanced mammography. Those are different because you can see calcifications, do something else. Not everybody has that. But increasingly, that's going to be around. And I think, the MRs are going to get faster and easier. And, these are all the things that can work. But there's also going to be opportunities for prevention. One of my colleagues from Austria is working on anti-progesterone therapies that look like they're going to be risk reducing for women who have these BRCA1 tumors. Now that PARP inhibitors are being used, we in I-Spy are testing PARP inhibitors alone or alone with DNA damaging agents to see, is that sufficient? if we actually have a really great treatment that isn't too toxic, it's going to change how people think about wanting to do prophylactic surgery. People, right? So these are all the things that you should know. That's why the more you know, the better it is. People used to say, oh, we shouldn't at the beginning. So when BRCA1 was cloned in 1996, BRCA2 in 1997, people say, oh, well, don't find out because then what can you do? Or you have to have a prophylactic surgery. You don't. There are choices. And, again, you just have to know what are my options and what are the consequences. And, those are the things. And that's one of and in the wisdom study, we find people who have that and we counsel them and we look at them. People make all kinds of choices. But back to a very important message for your listeners is if you had a mammogram that was normal 8 months ago and now you feel a mass, don't assume it's nothing because I had a normal mammogram. 50% of women still find their own cancers. So it's be very aware of your body. And if someone comes in, a physician sends me someone who they think has a mass, I pay the most attention to the patient who says, I've always examined myself. I've noticed something different.
So
you have to pay attention to that.
I think we want to tell women, and I know it's rather basic, not for us, but all our listeners may not have experience like you, Joelle, and certainly not all of them are physicians. So what's the best time of the month to do a self-exam? And what's the best way to learn about how to do a self-exam, breast exam?
So I would say that the best time, so I think most people are afraid of doing breast exam because they're like, oh my gosh, breasts are lumpy, bumpy. Well, actually, yes, that's true. Most breasts are lumpy, bumpy. That's okay. The UK actually had a great campaign, Be Breast Aware. And you don't have to make it some giant thing. If you just to remember it's the first of the month or like a week after your period, when your breasts are the least tender, you just raise your arm up, just move your hands up and down over your breast and just get to know what your breasts feel like because the most important thing is change. And you're the best at figuring that out. Oh, yeah, that's always been there. Oh, no, that is different. That's what you want to bring to somebody's attention. And that's just, it takes a minute. You don't have to do some 30-minute exam. You have to do a 1-minute exam.
So even a week after your menstrual cycle starts, when the follicles start making more estrogen, is a good time to do a breast exam, I think.
Yeah, I think the best time to do it actually is when you remember.
Okay, that's very practical. I can agree.
You can do it the first of the month. You can do it when you're in the shower.
Yeah,
you're already naked. You're already put your arm up. The water makes it easier
my
to feel
usual
things.
Place to do it.
Just be aware. Just be aware.
So Joelle,
right? I think that's
turning back to you. I wondered when you heard that you were BRCA positive. And did you understand the connection between that and your Ashkenazi Jewish heritage? Is that something that you were made aware of prior to that?
Yeah, the geneticist, I'm sure she would have a funny story to tell. So I was in business school in 1996 when the BRCA1 study was announced. And, my mother was the first one to ever have breast cancer. And I looked at it and I said, we're Ashkenazi Jewish because that was in the study. My mother was 36. Well, that fits. That must be us. Again, totally wrong, or turned out to be right, but was not necessarily going to be right. I know plenty of Ashkenazi Jewish women who have a lot of breast cancer in the family and are not BRCA1. So I just said, that must be it. I said, that must be it. And again, I believe you have to advocate for yourself and you have to build a relationship with your healthcare team. So any new physician or nurse practitioner who saw me was going to hear, my mother had breast cancer at 36. Let's just start and she is my genetic mother, like I'm not adopted, 36. I just want that at the top of the record. And let's go on to the ear, nose, and throat exam. Like, whatever. I just wanted them to know because I wanted the best eyes, the best hands on high alert, including my own, right? Including my own. And
but not being obsessive about it. In your case, it sounds like while you were in the cancer trenches for more than 4 decades, beginning with your mom, you seem to have come through it in a way that gave you the wisdom to be calm and face your diagnosis, realistically. Like, what do I need to do?
So, maybe I'm also a bit naive. I don't see anywhere near what the two of you see, right? I have a very small sample size, right? That, but it's pretty good. Like the people I know have done really well. And
well, actually, that's very interesting. There are people who come from families where everybody survived, and they have a very different attitude from the people who come from families where most people died. That makes people a lot more anxious.
I agree. That's why my family seems to be less concerned, even though they worry. We had one relative, but we related to her paternal side, who died at 36 with widely metastatic breast cancer. She was actually seen at NIH and had some chemotherapy and some surgery, and yet subsequently succumbed with cancer mets around her entire body, leaving young children behind. But the rest of my family, on my mother's side, also has very commonly diagnosed, and nobody has died with breast cancer or because of breast cancer.
Now, I want to reorient people's understanding about the Ashkenazi Jewish thing and BRCA. The reason why we made that association with Ashkenazi Jewish women is because they were the first, because some of the first testing of the BRCA gene was done in the Tay-Sachs gene bank. Which was all Jewish women. So it turns out that 1% to 2% of Jewish people, because it can come from your mother or your father, carry that gene. Well, guess what? If you are English, there's an English gene. If you are Nigerian, there's the Nigerian gene. Black women for a long time thought, oh, well, I can't possibly have a genetic mutation. That is not correct. Mm-hmm. Being Ashkenazi Jewish does not put you at risk for having a BRCA mutation. That's really important. And one of the reasons why we are trying to move the idea of population-based testing out is because, the more we test, the more we understand we're going to find in other populations what those other genes are. Because, genetics is really the study of populations and population migration and what happens to people. And so you can look in the Caribbean, in the Bahamas, for example, it's like a 20% risk of having a BRCA1 gene, whereas in, Jamaica, it's like less than 1%. So and probably it has to do with families that migrated one place. And, like people need to be disabused of the fact that, oh, I can't possibly have that, or I can't have breast cancer because I don't have a family history. Okay, definitely not true. So this is one of the things that we're trying to understand and say, look, it's just good health hygiene. Know your risk. Mm-hmm.
So let me just make sure I understand, because this is the first I've heard of it explained in this fashion, although I see the same through a different lens. For example, diabetes. There's tons of variants of diabetes in every population, and it's actually different in every group, an ethnic group. So with breast cancer, in the fact that it was uncovered in the first group of women that had Tay-Sachs or in a Tay-Sachs bank or were studied, is that why it got associated with Ashkenazi Jews? But yet it's the same gene, the same exact mutation exists in other parts.
So there are probably over 500 mutations in the BRCA gene. There are 3 common mutations in the Jewish population. Those are the ones that tend, and so don't be fooled by something like if you get 23andMe and they do those 3 genes, they say, oh, you have it or you don't. That's not correct. They've tested for those 3, does not mean you don't have anything else, right? They're not testing for all 500. So that's why we used full sequencing, plus looking at the many genes, looking at the whole genome to try and understand and take advantage of these other things that we're looking at. I mean, we hope all of health will be that way. Everyone gets a deck of cards, right? And some people get the king and queen, and some people don't.
I am completely aligned with that, and why I practice precision medicine at every level, looking at data and applying it in a personalized way and recognizing each one of us is unique. In the diabetes world, there are over 2,000, I think 2,500 gene variants that give you various forms of sugar, carbohydrate management that leads to some form of diabetes. So you already told...
And without the information, you can't figure it out. You can't really be helpful. You can't, right.
But there's a cost to getting that information, and access to some of that workup, whether it's possible or not, means it may be a hard reach for most people. Obviously, we're in the part of the population that seeks medical care and does it appropriately. So that's another hurdle too, for some of those populations who can't get care.
That's one of the reasons. It's one of the reasons why in the wisdom study, everything is free.
So the wisdom study is open globally or nationally to anybody in the United States. You don't have to have insurance. You just fill out what it would be the site that people would go to find it.
Wisdomstudy.org. Women informed to screen depending on measures.
Can men be screened as well? Because there's a population of men who get breast cancer as well.
There are, but even that risk is lower than the average risk of a woman, even if you had a BRCA gene. So it's just not reasonable to be screening men.
Right, that's great to know. I wasn't aware of it, and it's one of the best things, I think. It sounds like you've accomplished so much at UCSF Breast Care Center. And I think, Joelle, you went there as soon as your diagnosis was made or subsequent to your diagnosis? Or were you under the watchful eye of the physicians there?
I was not. I did go, it was 2 days after diagnosis that I had the opportunity to meet Dr. Esserman and her team. By the way, when I did do the genetic test, and they said, and I did it mostly so I could stop having biopsies, because if it was negative, I didn't have to be screened like that, because we knew that's what the risk, that was correlated.
Family.
Yeah, we were correlated. And so when they told me, well, you came back positive, I was like, oh, my poor parents. Like, that's literally what went through my head, was like,
a lot of people have guilt thinking, have I passed that on, right?
Well, and my mother did. And I said to her, I would still rather be your daughter with everything I got. Like, feel no guilt, no moment. We have no idea what's in that whole genetic soup or sequence that you both are talking about, right? But I'll take what I got. And that included BRCA and being vigilant. And in any population, I think it's important, like, yes, not everybody, unfortunately, can be screened, although if you join Wisdom, there's lots of stuff that's great. But you always have your hands. And you must know your body.
Let me ask you, you have 3 children. How many daughters?
I do.
But one daughter for sure.
One daughter.
Okay. What is your advice to your daughter now in terms of her risk, given the notion that it's obviously in your genetic soup?
So the first is, every time you see a medical care provider, you tell them that you have a strong family history of breast cancer, and it's here, here, here. You share information. Number 2, you know your body. You touch your body. You get familiar with your body, because you will be a phenomenal scout.
You're the front line
for any issues. I also tell them, this is not, look at our family. I really like the things Dr. Esserman is doing. I hope my daughter and my niece are in the group that we come up with a way that just diverts this, and they never have to face it.
I'm pretty confident we will.
Well, from your mouth to God's ears, I'm good with that. But every day you take a breath, there is risk in your life. That is what comes with living.
Yeah.
You get in a car, whether you are driving it or a passenger, there is risk in your life. So the fact that she may or may not have the BRCA1 gene, it is just one of many risks in your life. And the good thing, as ridiculous as that sounds, about the BRCA1 gene is we can identify it, and there are protocols, and there are phenomenal researchers, scientists, doctors who are committing their lives to preventing, detecting, and treating this as early as possible so it has as minimal impact on your life. Like, I'll take that bet. And she should too, and she does. And so of all the things she's anxious about, she's a senior in high school, I assure you that breast cancer and BRCA1 is down on the bottom of the top 10. It's not.
Well, she has even more experience than you do.
Yeah, and the next 10 years, we'll come up with much more precise treatments and things that are perhaps non-toxic. But it's also important to know that even today, no matter what has happened, it is possible for people to understand, oh, I do not have to pass this gene on if I don't want to.
Thank you.
There's pre-implantation,
examination of embryos.
Genetics, you can, and embryos, and you can decide, not to choose an embryo that has that BRCA gene. Now, as we say, everyone's got their own deck of cards, and that's just the way life is, right? But there are things you can do, and you don't have to take action on it, but it's important to know that you can. And I also believe that there are going to be, anti-progestins and things, even things like mifepristone actually look like they're going to be effective in reducing the risk of breast cancer.
Is that widely
BPA,
available?
other things.
Where?
No. These are
in the
in
research,
the testing setting,
right.
but we actually must be very vigilant because there is a political agenda in this country that is against testing things that have to do with reproductive health or birth control innovations or hormonal interventions. And this is a problem because we need better tests. We should be, I've started a new movement, a new organization called Rise Up for Breast Cancer. And we had for our first meeting last year, really trying to think about, well, okay, what can we start to do about really seriously reducing the risk of getting breast cancer? And every woman, has, times at which, their hormones might be manipulated from cycle control, birth control, IVF, in vitro fertilization, postpartum weaning, and postmenopausal hormone replacement. We can be thinking about how to organize those interventions with an eye towards reduction of breast cancer risk, as well as improving people's sense of well-being. And if you can do two things at once, how great that is. But we haven't used our imagination or our knowledge and science to really push that agenda. And that was actually one of the Spark Awards that we funded was mifepristone for BRCA1 carriers. And one of my colleagues from Austria has some really beautiful data showing that might be very risk reducing, but that also makes you think about other things. Wow, antiprogestins might, for people with very dense breast tissue, because progesterone is one of the causes of dense breast tissue, might be really a great way to reduce risk. We have to really invest in thinking out of the box and working to reduce the chance of getting breast cancer. I'm tired of hearing, I don't want to see us at 300,000 or more breast cancers diagnosed a year. It's not necessary. We can do better.
I agree.
And we must.
So turning a little bit or pivoting to the fact that, Joelle, you said the breast cancer really didn't keep you awake at night, but the idea of a mastectomy and removing your breasts did. And you went to your sister-in-law and got advice from your sister-in-law. What ultimately made you decide to opt for a double mastectomy?
Yeah. And the reason both my mother and my sister had complications post-mastectomy. So I did see some of the implications, and I did not view a mastectomy as a trivial surgery.
Which it is not.
Right. So
in any case,
I don't think we should minimize that when we say, oh, just have a prophylactic. Like, that's a major surgery. And
psychologically and physically.
Yeah, totally. And my mental state was, I'm well screened. I don't worry about this on a regular basis. And if they find it, they'll find it early. And then I will do a bilateral mastectomy. Like, I didn't have there was no question in my mind, to the point where when I started dating my husband 28 years ago, I told him that. I said, just make sure you're signing up for this particular journey. Because if this fork in the road, which has some unusually high probability, happens, I'm taking the right. They're going. Enjoy them while we have them. So, and I did things to reduce my risk, right? I don't smoke. I don't drink. I exercise. I nursed my kids for a year each, which I enjoyed. But all of that also was risk reducing. And sometimes the cards come up. So why did I decide to do it? I had yet another biopsy. And every time I had a biopsy, I did go, that brought me to the dark place of, is this the time? Will this be the time my number comes up? And I was 52, and my sister said, why don't you just explore what your options might be for reconstruction? Because that was really where the complications were for my sister and my mother. So I met with a plastic surgeon that's in a group that specialized in the deep. And he both told me I didn't have cancer because he had the biopsy results, and told me a couple of things. He said I was a good candidate. He also suggested, he was like, look, it's a big surgery and you're very healthy right now.
Yeah.
Why would you want to do this? As you get older, you are by definition likely to be less healthy than you are right now. That may not be the case with some of the work you do, Florence, but, aging happens, and, it's harder to recover if you're less virile. And so he said, why would you want to wait? And then my sister-in-law said, and why would you want to put your family and yourself through chemotherapy? And so they both made this case. And I said, and then Heather She said, and by the way, if you do it prophylactically, you control the schedule. And how great would that be? You can decide when this is going to interrupt your life. I said, oh, that suits the little control freak in me. And so, I scheduled it out, and I even did a reduction because they were worried about,
Well, yeah, you can, if there's, so one of the things that has really improved breast reconstruction is the ability to save all of the skin envelope, including the nipple skin. Some people save the nipple, but really it should just be the nipple skin, especially if you're a carrier. But that, if you are large-breasted, you can't both save all of the skin and do it at the same time. So you have to reduce the size in the skin envelope, then let it heal, and then go do that in 6 months.
So I actually did it in 3, but I did
Well, you didn't. Exactly.
I didn't. I was planning to.
You were planning to.
The game plan was to do that in 3.
What was the point of the nipple? Can you state that again in case some of our listeners would like to understand?
No, it's really it's really important to know. We used to always take off the nipple. So first it was, you can't do reconstruction at the same time. There's a lot of myths in medicine. A lot of people think, oh, this is the way it is. So, we used to do this mastectomy. We'd take off everything and then you'd be flat. And then we'd go back and do reconstruction. Quite frankly, they were not very attractive and, they never looked natural. And then we started trying to save most of the skin and taking the nipple. And I was giving a talk to a group of women and I was explaining why we had to take the nipple. And they said, well, how do you know? I said, well, it doesn't survive. They said, well, have you tried it? How do you know? And I thought to myself, this is back in 1998. I went, oh, actually, I haven't really done that. We really don't know. So I was trying to think about it. So early on, so I spent about 6 years developing and testing all these different techniques. And in fact, I started it because there was a woman with a BRCA1 cancer. Everyone in her family had died. And she, I was like, okay, why? These terrible cancers came up like this.
Mm-hmm.
They were absolutely, rapidly lethal. And I said, look, and I said, well, would you be willing to do it if you could save your nipple? And it looked the same. And I look back at it at the time. So I was doing a registry and getting consent, but I really didn't know if it was going to work.
I'd like to be patient zero.
And I did. I was perfectly honest. And I said, I'll tell you what, I will work to figure out how to save all that if you will consider getting rid of this tissue that's trying to kill you and everyone in your family. And it worked. And the thing that's so amazing is you can't, even if you reconstruct the nipples, the shape and size of the breast just doesn't look normal. You can't create that kind of ski slope look that most breast people, most people have. And it is one of those things that over about a 5-year period of time, we figured out how to really do it well and not well. And, over a long period of time, we've really worked on trying to do quality improvement to figure out how to do it better. I mean, there are some risks. No matter what you do, you can do the same operation 100 times and things go wrong. That's just the way it is, right? And it's terrible when it does, but that's the way it is, right? So, but that's what I'm saying. You can save the nipple skin. And it absolutely, there's almost nobody that we can't do that on. And if someone tells you it can't be done, that is incorrect. Go get a second opinion.
So that is a wonderful insight. And I just want to mention that besides reproduction and being able to do pre-implantation genetics on the embryos or the eggs, there's also a concern about nursing that has come up in some of the younger women who talk about wanting to have children. Maybe they had children already and they nursed and they're thinking about future children. Maybe they've put away eggs so that they can carry, they can actually conceive post surgery and intervention. What has been your experience at that end?
Oh, so one of the first things that we ask people who are young, whether have children or haven't had children, is having children important to you? And anyone who's going to have a type of therapy like chemotherapy or even extended hormone therapy that would delay their time of conception to a time when they wouldn't be fertile anymore, or where the treatments themselves can increase infertility, then, you have to say, is that important to you? And do you want to save preserve your eggs. And the truth is that it is safe to take the time, even if it takes a month to harvest your eggs. You can do it, and that is safe. It's important for people to understand what your options are, and that, as I said, breast cancer is an emergency because you know it. You have the time to do the things that are important. Nothing is worse than having that door shut for you.
That is very important.
But I think nursing is a thing. Like my sister chose to have a lumpectomy and radiation to preserve the possibility that she could nurse from the other breast. And then ultimately, after she'd had her 2 children, she did do the harvesting, and they were using, is it Lupron?
Lupron.
Yeah.
GnRH analog,
Lupron.
yeah.
Right. She was in a early study of that. So to Dr. Esserman's point about ask about clinical trials, she was in that. It preserved her fertility. She had 2 children. And then after her second child, met with her oncologist and said, if this comes back, what are my options? And the oncologist said, not great. And again, this was probably 2010. So
not too far
options
away,
have gotten
right?
better and improving. Right. But it's amazing how fast things are changing. So she chose to do a bilateral prophylactic after she had nursed her children. So she did the treatment, the chemo, the lumpectomy, the radiation. She did nurse. She could only nurse one side. The other side, she's like, it's trying, but it's just not getting there. But she was able to have some of that experience. And then she elected to do the more extensive surgery.
Yeah, so that's wonderful. I think it's a good point that we make. If you have a bilateral mastectomy, even if you conceive subsequently, you're unlikely to be able to nurse a child if
you've had a mastectomy,
bilateral mastectomy.
You can't. No
exactly.
nursing after that.
A bilateral mastectomy, you have no breast tissue. So
let's hope you can't nurse after that.
Although there are some hookups even for men that feed the nipple, and I don't know if you've ever seen this, but when I was at NIH, there were some gadgets, and if you let a baby suck, there were some men who wanted to try to nurse. After a while, sometimes the breast tissue seems to respond to that because it's my background in reproductive endocrinology. Let me move on because I'm afraid we're going to run out of time. Yeah.
We have to let Dr. Esserman go. So I can stay a little bit longer, but I think Dr. Esserman
I'm happy to come back another time to answer other questions and talk about, we can actually talk about Rise Up and talk about the whole idea of hormone replacement after breast cancer, and what are the pros and what are the cons, and what are the things we know and what are the things we don't know and must continue to study. Okay, fantastic. Thank you so much for having me on, Joelle, as always.
That's great.
Great to see you. Great to see everybody.
Oh, yeah. Okay. All right.
So, Joelle, I want to wrap up, but there's not too much left. But because I'm a baseball fan, and it was the Yankees, now it's Mets, because I have a grandson who's a crazy Mets fan. So we actually started a podcast, Good Morning Mets Fans. I encourage you to look for it.
Awesome.
He's a natural.
Awesome.
And I love your baseball analogies in the book and the terms you use like curveball, first inning, dugout, camaraderie, home run for the chapter headings. Why baseball from your perspective?
So a couple of things. One, I always thought of cancer as a curveball. Just the metaphor made sense. But when my second boy was 2 years old, we lost him in a playground. Terrifying. And only found him by spinning around and seeing this blonde child crawling up the backstop. And he was just called to baseball, and turned out he was quite good at it. He's playing at the collegiate level now. And I have watched more baseball than I ever intended to watch. And people say, what's your favorite team? I'm like, the one my boy is playing on. That is my favorite team. But he is a hitter. He's an outfielder. He's a hitter. And so I asked him, what went well at that at-bat? What did you want to do, et cetera? And he started talking about something called approach. And I realized I was doing something very similar in the corporate world. And ultimately, I did that with my cancer, is that I had an approach, a mental game that I was playing and preparing for each appointment, for each infusion, for the surgery, for post-infusion days. And when you unpack it, approach, it's like preloading the frontal cortex, right? It actually makes us calmer. It makes us a better listener. It makes us more decisive because we've pre-processed some of the questions, some of the concerns, and we've been able to sort through that hormonal surge of reaction when we hear something or think something scary. We've got an approach.
Makes sense.
Right? So,
Yes.
so from that, approach is key in baseball. And it turns out approach is key in cancer. And I assume it's probably key in diabetes.
It is.
Right?
Approach is used formally in baseball. That's an approach when your son shared that with you.
Absolutely.
Fabulous.
Yeah. If you ask is it your grandson or your son? Your grandson. If you say to him, what was your approach for that at bat? He'll say, wow, you know about that? But it's everything from what pitch they're looking for, how they're, what's going on the field, what they want to do with the ball. But it makes
a ton of sense. And I remember giving a talk many years ago when my father passed, but right after my father passed away, and it was very hard for me. And usually I don't design approaches. I might design the way I think about an approach, but I don't lock in. And in this case, it was such a hard talk because he'd always been at my talks that I came up with an approach that involved using chocolate. And it was a huge audience of women, which was fabulous. It was the best talk I think I've ever given. I had a line out the door because everybody loves chocolate, but I framed the whole talk using chocolate and chocolate terminology. You also mentioned the batting helmet, and I think that was about chemotherapy. You needed a chemo course, which I know Dr. Esserman Laura went through, that it isn't necessarily surgery first. And then what's cold capping?
Sure. Cold capping is a FDA-approved innovation where there's a number of different devices. Mine plugs into a machine that UCSF has that cools your scalp to just above freezing. And it turns out that by freezing or just above freezing the hair follicles, they absorb less of the chemotherapy. And the chemotherapy isn't for the hair follicles, but any rapidly dividing cell is a high target for chemotherapy, and your hair is one of those things. So the cold capping reduces its uptake and can preserve a lot more of your hair. So I like to tell people, I don't know if we'll be on video or not, but I had cancer 2 years ago, and this is my hair.
It's gorgeous.
Right?
Right?
I have a lot
so
of
you
hair.
You didn't lose your hair at all.
I lost about a third, so I have a lot of hair. I lost some, but I never needed a wig or scarves. Now, other people do, even when they cold cap, and every protocol is different.
Does it grow back? Is the third that you lost, did that come back?
Yeah,
Good.
Totally. But people will tell you, it's like chemo hair grows back funny at first. Like it's kind of saying, what did you do to me? And then over time, it normalizes again. And so, your life comes back to, it can be as similar to your old life, again, maybe with some different body parts. I wanted to go back to the nipple preservation, because you can get 3D tattoos. Some women do beautiful tattoos over their breasts or what have you. Wasn't my thing. It really was very comforting to know that once my body healed from the surgery, it was going to look a lot like my body before. And I haven't needed a new wardrobe.
That's reassuring. That's
fit.
Fantastic. Yeah.
Yep.
I love a part of your book, The Lessons Learned, where you summarize the takeaways from each chapter at the end. Is that something that you also thought about, that approach and how that would be meaningful so people could walk away with what they needed to do next, or what to think about, how to organize it for themselves?
So it was deliberate, but it was deliberate from the perspective of, if you're actually newly diagnosed, you may not want to read the whole book. You may just want to read one chapter, one segment, because that's what's going on right now. And you don't want to know what the whole story is, because that's not where you are. So I wanted to make each piece complete if that's all you read. And if all you wanted was no stories, no anecdotes, just give me the facts, then you read the conclusion at the end and there's no stories. It's the summary of all of the summaries, right? And because sometimes people don't want to hear any stories, and that's okay. And Florence, it's really important that people know, like, my experience, I was able to make it a really happy journey, but there were times I was sad and mad and was angry, and sometimes I didn't feel like being strong, and sometimes I didn't feel like being positive. And it's okay for people to feel all of those feelings. And what's important is if you care about someone going through cancer, you can give them a moment of happiness just by saying, I love you. Can I take a walk? Right? You can't fix the cancer. We have to leave that to doctors and all of that. But you can send moments of joy. And those little moments of joy actually release, the hormones they release,
wonderful.
Right?
Yeah, wonderful advice.
They're wonderful, right? And that boosts everything.
In fact, I loved your opening. I was going to ask you a little bit more about singing. And I know that that Laura asked you if I think you asked Laura, could it be a duet, right? And the song you chose was meaningful to both of you. Where did the practice come from? And what was the song that you actually ended up singing together?
So I think her practice, first off, Laura is just a big personality full of life. And I think that she loves to sing. And she's actually trained in opera. So she could sing you an aria, right? And that's fabulous. And so it's a way of bringing herself as a person into the patient-doctor interaction, and makes it a lot less clinical without violating any ethical boundaries, right? It just makes you human. So I think that's where it came from. For me, I've been singing my whole life as well. I'm not an opera singer. I wanted to keep focus on the days to come. I knew that the days following surgery might be painful and uncomfortable and uncertain, but I also knew they were not going to be permanent. And if I could keep myself focused enough, even having plans and milestones to aim for that could say, I might feel like crap tomorrow because they've removed my breasts, they've taken belly fat up, and I've had all kinds of things happen to my body. But in 6 weeks, I want to be on a plane going to watch my son play baseball. Like, that's what I want to do. And I can see it. I can manifest and visualize it. And that is Don't Stop. So that's why we chose Don't Stop from Fleetwood Mac. Don't stop thinking about tomorrow. Not going to sing it because they're very big on rights and I don't want to get you in any trouble. But my husband recorded it. We have it on video. He sent it out to all of our family that were, concerned as I was going into surgery, basically to say, like, this is going to be okay.
You know that there's data about that and being optimistic and sharing your story that shows that it's much more likely to survive if you can be optimistic and go to support with family, pets. There's data on many diseases in that, but particularly in cancer and breast cancer. So you had a lot of support. You were an incredible patient, and you were so active in every step from diagnosis through surgery and follow-up. Do you think people can take bits and bites of your story and learn how to navigate, even though they're going to have their own experiences and background that they bring to the table when they're diagnosed?
I think not only do I think they can, I think they have to. And the interesting thing, Florence, is I interviewed about 25 women for the book, and we included about 12 of their stories. But everyone at the end had realized they started taking control. They started making more of a plan. They started owning. And this is the crazy thing, none of us want cancer, like nobody. And all of us felt like our lives were better afterwards. Maybe with different body parts, but because, cancer is the great clarifier, right? When you're facing cancer, a whole lot of other stuff is very clearly small stuff. Yes. I'm sure you have this.
No, I definitely do. I have
as well.
I had a brilliant woman who was a friend and a patient at one point, and she was a COO of a very well-known company, and her husband, and there was a lot of cancer in their family, a lot of breast cancer. And every time something came up that was disturbing to them or to me, because I worked with them, her husband in particular, he's a lawyer. They were both brilliant. And the line that he always uses, it isn't cancer. And so I think it's also the great unknown. It does level you because you go through it, and, once you're through it, you kind of feel this huge weight off of you. For some people, it's hard to get that weight off, though. They're always afraid. And that would be, I don't know sometimes how to help those patients, but that might be something you can help with and your book can help with.
There is this amazing specialty that I didn't know existed until my own cancer journey called psycho-oncology. And these are mental health professionals, psychologists, who are trained specifically in the experience and the issues of cancer patients and their family members. So what I say to someone who can't get it off their shoulders, who it's weighing them down, there's help. I'm happy to be a source of ideas through the book and what have you, but there actually are professionals who've seen this before. You're not the first person to have trouble. And what often people say, Florence, is you finish treatment. And I mean, when you're in treatment, it is the center of your life. Like it is the sun and you are rotating around it because you have different appointments and it's just interfering with your life. And then it ends and they say, see you in six weeks or see you in 3 months. Like, wait, don't you want to see me next week? Nothing to do with you next week. And there's a void. So a lot of people actually don't know how to fill the void. Do I just go back to everything the way it was? Does my cancer not mean anything? And your cancer doesn't mean anything. It literally is disease, cells run amok. It doesn't have meaning or consciousness. If you want to use it as a catalyst to make a change that you want to make in your life, great. And if you don't, great.
So rejoin the world, and you have to adapt a little bit. I'd love to hear an update on how you've sort of shared where you are, and it sounds like your journey was particularly actually inspiring. How about your mom and sister?
So we had a party last week to celebrate the book. My sister lives about 10 miles away from me. She did have, I think we wrote about this in the book, she did have a second primary 20 years after mastectomy. So a very tiny, it responded fully to chemo. And to Dr. Esserman's point, because they didn't take out the little tumor, but they did the treatment first, they saw how her little tiny tumor responded, and it actually led them to not do the full cycle, which was good because every cycle is more and more toxic. So I only had to do the cycle of carbotaxol with my drugs. I didn't have to go do AC. My sister didn't have to do a whole cycle of her treatment. She got to do a partial because her tumor responded fully. She is also healthy. And look, it's aggravating. You don't want to see this thing again and again. And, I don't want to ever see it again. But you got to make each day count, not with pressure. Like some days are just, so-so days, but you can still, if you can express or feel love for a being, a pet, a person, a memory, like that's a good day.
Yeah, gratitude. I wake up every day and I promised myself last year, and I'm keeping to it, to be grateful for all that I have and all that I am, no matter how bad the day is. And you wrote at the end of your book, there's a quote, every cancer patient that spends time feeling like a victim, because cancer can really suck and completely derail your life. So what's your advice for someone at that point? Is to find those moments, is to go for a walk, reach for a friend, do something that can take them away from where they are at that moment?
So I think it's a two-step. The first is it's okay that you feel that way. And give yourself permission to feel it, to rage. You want to go to a rage room and break things? Break things. You want to write a letter about how much this sucks? Write it down. Actually, writing it down is very therapeutic. And you can keep it, you can shred it, you can burn it, whatever. But don't resist the feeling, because what you resist persists. But what you will find is it's like a flame. It burns out pretty quickly. And then you're just sitting here saying, like, now what? So the idea of happiness tripwires, which are in the book, is to have inevitable things on your path that just make you happy. So I enjoyed washing my hair once a week, or I tell the story of my baseball player sending me a letter every infusion, just telling me about his life. It was digital chocolate, to your chocolate metaphor. Digital chocolate. It was so good. I had people who would send me a joke or a meme or a stupid thing their
So
pet did.
reach into your community, like make sure wherever your
Yeah.
community exists, maybe it's your church or synagogue, maybe it's your friends, maybe it's your next door neighbor, maybe it's your family, whoever it is, be there, reach out and get some support.
And tell them it's not that the support you probably don't need is, how are you doing today? Like, stop it, right? Like, stop it. Yeah, I don't want to have that conversation over and over again.
So I want to end because we've gone on longer, and I'm grateful for that, because I think our listeners are going to really enjoy hearing and reading your book ultimately, because it's honest advice from you who have been through it all and more, really. So you've brought a lot to the table. I would recommend it very highly for anyone who faces cancer and their families and friends and loved ones. So I'm hoping to get it out there, and maybe we'll even keep some copies here for people, because I've been managing people who through my treatments have been picked up to have cancer, and I think it will make a difference. It comes from a very positive place. I really appreciate you being here. I do have and Dr. Laura Esserman, so I'm sorry we lost her at the end, but she contributed so much about what's going on at UCSF and where she played this major role and how she thinks people should deal with facing a diagnosis, not to rush in overnight to surgery, but give it time and figure out what the best course is, as you mentioned, for yourself and your sister. I'd love to ask you a question. I like to include this in the podcast. If someone just stopped you on the street, or you met them at a party or on a plane, and they ask you, and they may know you because of the book, what's your best piece of advice for living an optimal life? What would you say?
Wow. Love with abandon.
Wow, that's fantastic.
Love with abandon.
Yeah. That's hard sometimes, though. That means exposing yourself and letting go. I know.
It does. But you know what? It's like the world is a mirror. You love with abandon, and love comes back to you. And when I talk about the number of people who sent me expressions of affection, love, these are people I work with professionally. These are not people that are just my family. And I send it back out to them, because if you're in my life, you matter. You matter to me. And, I think it's so important to just tell people you matter.
So I'm glad I'm in your life now. I am glad that this came to be. I know I owe it to Stephanie Telenius. So thank you so much. And sharing your insights and inspiration with our listeners, my audience. I know it will help everybody who takes the time to listen.
I hope so.
Yes. Great. Do you want to give us where the best place to get the book? Can you buy it on Amazon? Is it in bookstores? Is it on Kindle?
So you can buy it as an ebook, Kindle, Nook, whatever. You can also buy it as a paperback, but only available through online sources. It's not in bookstores, but any online store you like to frequent, Amazon, Barnes & Noble, everybody else, you can find it. It's Crushing the Cancer Curveball, a playbook for the newly diagnosed, their family and friends.
Great. And is there any contact you want to share if people want to reach out to you, or is that something they should do through the book?
So the book has QR codes that will lead you back to the website, www.joellekaufman.com. It will lead you to various tools that I created along my journey, things like tracking side effects. And it sounds silly, but you see your doctor if you're going through chemo maybe every 3 weeks, and they say, how was it? And you don't remember 3 weeks ago. You probably don't remember 3 days ago. But if you keep it in a tracker, you can share it. And I actually ended up sharing the link to my tracker with my care team, because it turns out my care team, they're great at looking at patterns and saying, oh, you seem to be taking Zofran a lot. Well, I wanted to avoid nausea. Yeah, but it's actually making you very constipated. So let's see what happens if we reduce that. And here's what we could try. And it was just great. So information is power, but you can't keep it all in your head. So the QR codes in the book will take you to joellekaufman.com, or you can go to Joelle, Joelle, Kaufman, Kaufman.com. There's a way to get in touch with me there, but there's also a bot, and you can ask it questions, and it will answer nothing medical because I'm not a doctor. But if you have questions about how to live through this and ways you can improve your approach, the bot is there 24/7 for everybody.
Well, I'll have a new resource now, along with the book, for people who are feeling that they might wake up at 3 a.m. and need, really want to reach out and find out some question, something that's been bothering them or woke them up at 3 a.m. Well, I'll tell you, this was very rewarding. I've had my own experience as both a doctor, a friend, a family member, and I did learn from 2 women who are much like you. And they were very high-powered women, each of them. I diagnosed the cancer in one of them. She was quite young. She was 48 at the time. And the other one had been diagnosed, but then came to me for care. And one thing they shared that I found fascinating, because I didn't see it from that perspective, is how these women who live very high-powered lives felt during their therapy that they hit a wall, and that it was easier to understand some of the people that worked with them, because when somebody would say to them, I just can't do anymore, my mind is blown, or the chemotherapy and the treatment themselves really wore them out. And they had to take really good care of themselves. And both of them went out of their way to find people to say, okay, it's 3 o'clock, you're really finished for the day, let's get you out of here. Because they would not necessarily be able to have the strength to do that themselves. Or they'd be driving home and have to pull over because they were so fatigued from thinking about it, dealing with it, and living through it. So they lived their life to the fullest, and both of them, I'm thrilled to say, are alive and well many, many years after the diagnosis. But it was a lesson I've learned, and I've learned many from my patients. So thank you for sharing your story.
Yeah, and I think that empathy is wonderful, the empathy that they felt, that they gave themselves, the listening to your body. But I also want to say a lot of people sideline people when they say they have cancer, because they're proactively saying, I don't want it to be too much for you. So if we can share with your listeners, ask them. Don't sideline them.
Ask if they're open
do you
for...
want to do
yes,
this project?
Ask them.
Do you want to do this trip? Do you want to do this meeting at 7 o'clock at night? And as cancer patients, we have to be able to say, yeah, no, that's not going to work. That's just not going to work. I have to take care of myself.
That's excellent advice at every level of taking care of yourself. Advice I can use. So thank you very much, Joelle. All right. I think that's a wrap. It went on longer, but I'm grateful for that. And I hope we could stay in touch. I'm out in the Palo Alto area, and periodically I'll be there next week for a few days. But I will be sharing your book. And if anything else comes up, let me know. And maybe we can do this again and revisit where things are at, like a year down the line, 6 months down the line. If it's okay with you, I'll also share the book with people. If they want to reach out, they can reach out at your website, joellekaufman.com. Great. Okay.
Yep. All right. Thank you so much
Take
for
care.
the opportunity.
Enjoy the rest of your
Florence.
night.